Right. I would like to welcome back to Direction, Not Perfection, Dr. Nicole Levitt. She was born and raised in Winnipeg, Canada, graduated first class double honors with a Bachelor of Science in both biochem and physics. Ooh. Thereafter, she currently earned both her MD or PhD in pharmacology and therapeutics, specializing in insulin resistance, metabolic syndrome, and pregnancy. After residency, Dr. Levitt went on to practice as a physician, educator, medical director. Oh my goodness. And we are so lucky to have your time today and your wisdom. So we're going to take advantage. Welcome. How are you?
I'm great. How are you?
I'm good. All right. So we're just diving right in. For any of our listeners who missed our last episode, we kind of did this all things menopause, perimenopause hormones, which we'll circle back to and touch base on. But today our focus is going to be insulin resistance. And I was thinking it's one of those words that is thrown around all the time. And I
hmm
would actually like for you to give us this like college 101 course on this of just break it down. What is it? And then when should we be, or how should we be testing? And then what do we do with those test results? Okay. And
Sure.
also your turn.
So, insulin resistance is thrown around a lot. Insulin is a very powerful hormone in our body that regulates where sugar is going to go. So, when insulin binds its receptor, it causes the cell to express glucose transporter that goes to the surface of the cell and allows glucose to flow into the cell. So, there's a multitude of different GLUT transporters, and they have different numbers, and insulin binding the receptor causes all the signaling for that glucose transport to occur. So if you have insulin resistance, what that means is when that insulin receptor is binding the insulin, less of the signaling is happening. And what happens in the body when a receptor like insulin receptors are constantly stimulated, it actually downregulates the signaling. So you get less glucose transporters to the surface of the cell. So more of the sugar stays in the bloodstream or outside of the cell. And over time, you need more and more insulin to get the same effect, the same glucose transport. And what that means is you basically have higher and higher levels of insulin, but you get less signaling. So that's why it's called insulin resistance. You're basically resisting that hormone.
Mm.
The problem with that is insulin itself is fairly toxic to the body. High levels all the time can contribute to all of the things we see in metabolic syndrome, such as high blood pressure, peripheral vascular disease, where you get poor blood flow to your arms or your legs, heart attacks, strokes, plaque buildup. And if you don't get that insulin down, then that signaling, it's kind of a slippery slope towards your body's just going to leave that sugar outside the cell. The sugar itself is also dangerous. And then over time, the high fasting insulin levels will also contribute to putting on body fat because it's a signal that we should store everything that's out there, whether that's into body fat, glycogen. There's a very limited amount of glycogen you can actually store in the body and in the liver. So once that's overwhelmed, everything turns into fat.
Okay, so let's just summarize that for a second. So our body is overstimulated at just making too much insulin that we're not even capable or able to work through at that moment. And then because of that, we start into this storage type thinking, again, with fat storage as well as sugar. Like we can't do anything with the sugar, so there's
Yeah,
excess sugar that's floating around. Is that
exactly.
okay?
And then that high sugar, the liver takes a big hit with all that extra sugar laying around because the liver is our big, basically our dumping ground for everything that's toxic in our body. And it actually will turn a lot of that sugar into triglycerides. So then you'll have elevated triglycerides on your lipid panel. And we know that an elevated triglyceride to good cholesterol ratio is a very big risk factor for heart disease. And so you end up with your body trying to compensate, and our bodies sort of live in the moment. They're not worried about what's going to happen to us 10 years from now. It's worried about what's happening right now. So it will pump out more insulin acutely just to deal with the acute problem. Although long term, that's a big problem. In the short term, you just keep pumping out more and more insulin until eventually you actually can get pancreatic failure and end up as a diabetic on insulin, or so much of your pancreas is destroyed from getting fatty from the fat storage from the high insulin that you can get pancreatic failure from that too.
Okay. And most people have heard, like, if they have lived with a family member or lived it themselves with diabetes,
Yeah.
then a lot of this talk and like down the road type thinking, I think, is kind of known. So I want to take this back to insulin resistance is not just a diabetic thing. Anyone listening to this episode, even if they've never thought that they're worried about pre-diabetes, diabetes, I don't even know if you believe in the pre-diabetes phase of that, kind of walk us all the way back to what would start to cause issues with insulin resistance
The
to start
beginning.
with. Yeah, yeah.
Yeah. So the beginning is, let's say I wake up in the morning and I eat a big bowl of oatmeal. I put honey all over it. I have no protein with it. That sugar in the oatmeal and the honey hits my bloodstream and spikes my blood sugar. Then my pancreas has to deliver a big load of insulin to allow the blood sugars to come down. If I keep doing that every 2 to 3 hours, I have a big sugar load. Eventually, that high insulin level will never get to come back down to a fasting level ever. So my new baseline will be slightly higher over time. And then eventually my body will have so much insulin exposure that it will downregulate that insulin response. And it'll leave a little bit more sugar in the system, requiring a little bit more insulin. And so gradually over years, that's called postprandial hyperglycemia, or after you eat, your blood sugar goes up. That contributes to the insulin resistance. So it's a chronic hyperglycemia after you eat, or chronic sugar spikes lead to chronic higher insulin levels. So in my patients, I'll measure a fasting insulin level as part of their baseline labs. Healthy fasting insulin should be under 5. I would say 90% of my patients or more have a fasting insulin level greater than 5. So they're already showing signs that they're compensating for blood sugar spikes after they eat. So
Okay,
that's the beginning.
yes, and two takeaways with that. Let's talk about, because there is a normal spike and normal drop that can be happening where our body is supposed to be getting that. Like no one's going to stay at this baseline after
Mhm.
they've eaten. They're going to see a spike. And so I want you to go into what does more normal look like versus when we're requiring too much of our body to bring that back down, that blood sugar back down.
Well, what's interesting is it's different for everybody. So your
Okay.
genetics, your what you ate as a child, any chronic diseases you have, inflammation will all affect how much that excursion, that glucose excursion, will be damaging to you or a healthy process. I would
Hmm.
argue that you should always try to minimize those blood sugar spikes because we have such a high carb diet, so much processed food exposure and other toxin exposures, and our hormone levels aren't as good. And thyroid hormone and other hormones regulate our insulin sensitivity as well. So you're playing with less rope. So you get up to 160 after you eat a banana. Is that going to cause a problem? You won't know until maybe 3 years from now. And we know that everybody that has extra body fat, which is 70% of our population, they have insulin resistance already, or they wouldn't be storing too much body fat. They'd be at a normal ideal body weight.
Interesting. And so this goes back to just simply by eating protein with the banana, we could be bringing that spike down and less
Yeah.
requirement there. Yes.
Or
So
people
you're
that have, insulin resistant syndromes, they can eat more proteins and fats so that they don't require insulin to regulate their blood sugars to the same extent.
yes, which maybe this is too soon to go into this topic, but I did want to talk and pick your brain on this continuous blood glucose monitor. And again, for the non-diabetic, the person who's just very curious what's
Yeah.
happening with their blood sugar levels. I'd love to hear your opinion on that. If you think it's like too much, we're seeing too much that we don't need to see, or it's perfect.
I use them in my patients to help them learn what their body does when they eat certain foods. Because I can tell you, I really don't think you should eat bananas anymore because you're pre-diabetic and you have cholesterol problems and you're overweight and you have insulin resistance, and that banana is going to contribute to your insulin requirements being higher. It's one thing for me to say that. It's another thing for them to put the glucose monitor on and see what the banana did to their blood sugar, and that the blood sugar stayed higher the rest of the day. And they got bigger spikes from eating the same foods later in the day just because they had a banana in the morning. It's a very
Mm.
helpful learning tool.
It's interesting because, okay, so from dietitian world over on my side, we're always looking at all foods. All foods have a place, all foods, because we need all nutrients and we're going to gather
Mhm.
them from variety. And so this banana topic is like big controversy as
Yes.
far as, so I would almost like to take the banana talk and do like the continuous blood glucose with, again, with appropriate protein with it. Like if
Mhm.
paired correctly, does the theory of all foods still work or not? Or does a specific food really make that big of a difference?
I
So,
think it depends. Yeah. If you look at how many calories people could eat in the 1920s and what they weighed, they ate 1,500 calories more a day and they weighed a normal body weight. They were able to handle that food that they were eating back then much better than we can right now, clearly, because people have never weighed more and been less healthy. It's very complicated how we regulate our body weight. There's lots of hormonal influences. Maybe we can't get away with eating bananas anymore. Number one, because we're sick metabolisms already to start with. And bananas and all of our produce has changed a lot. There are a lot of them have been genetically modified and crossbred to become sweeter and have less fiber and be bigger. So if you look back at what a banana used to look like versus now, they're almost unrecognizable. Same with carrots and potatoes. Things have changed dramatically. And then that idea that all foods are healthy for you if used in moderation, I don't know if that applies to our current food supply.
which is really interesting because then what my brain goes to like, okay, well, people back then were working out more because they were farming, they were moving, they were walking. Like if our activity level remains great, can our variety of food? I don't know. I feel like now I want to do a whole science experiment with.
Well, there's exercise regulating your body weight is not really accurate. You can't outrun a bad diet. You can't outrun a metabolic problem. Exercise is compensated for by slowing of the metabolism. So I don't know really if there's a way to argue that we could maintain a healthy body weight if we exercised enough.
But like with exercise, just specifically with the blood glucose monitor, do you find that that looks more stable with your individuals who have a nice workout routine going, or does that not
Yes.
really playing into?
It
Okay.
does it does help lower the blood sugar and improves insulin sensitivity, but only to a certain extent. Like you couldn't drink juice all day and work out and still maintain a good blood sugar.
Hmm. Okay, so I do think the interesting part is that again, this goes back to individualized, right? That
Yeah.
you could wear the blood glucose monitor, I could, and we would both discover different things about our own body, right? That
Yes. One interesting thing is if you go and do fasted cardio, a lot of people actually get a blood sugar increase because their
Hmm.
body's mobilizing glycogen to maintain blood sugars for exercise. So it's actually
Hmm.
interesting to be like, hey, my blood sugar actually went up.
Then you don't see
That's
a quick drop hours later with that? No.
mm-mm.
Hmm.
Well, I mean, it depends on
Yeah.
the person, but
Right. Right. No. Okay. So let's go back to again the average person. If they wanted to throw something like this on, but they don't feel like they have a lot of symptoms going on, what do you think with the cost? It's a couple $100 depending on where you're grabbing your monitor from. Do you feel like it is a well worth cost for any individual or just somebody who's needing to investigate because they have strong symptoms going on?
I think it's a good idea for everybody to wear it for a couple weeks just to figure out what their blood sugars are doing. They've used them in studies for actual weight loss in non-diabetics, and they do help. It's sort of like food journaling. It keeps you accountable. And you sort of don't want to eat something too junky because you don't want to see the big blood sugar spike and you burn your beautiful curve. So I've seen them as low as Libre 2 monitors are about $60 for 2 weeks for cash, depending on the pharmacy. And they have
Mhm.
a free app. So it can be a cheap way to investigate your own physiology.
Yeah, that's good to know because I really haven't heard much under 200 and needing like the whole program with it where you get the dietitian, which I like. I love that you
Yeah.
can have the whole program, but if you just wanted to see some numbers. Now,
Yeah.
can we also talk about this because I think again from like the emotional standpoint, we have to be wise researchers that we have to understand that that number is in fact going to go up. but how far up or how long it stays up makes this big difference. Can you talk our listeners through, if they were going to go invest in this for a few weeks or a few months, what are some watch outs so we don't go like crazy overseeing a number and it's not even accurate?
Yeah. So the main thing is like these glucose monitors can be off by 5 or 10 or more points. And when we have insulin dependent diabetics, we have them finger check if there's anything that's super out of range, like, oh, are you actually as low as 40? Check your actually finger poke.
Yes.
So you'd have to take it with a grain of salt. And then the other thing is when you're looking at your overall patterns, you sort of want to see as small an area under the curve as possible. So you don't want to see big up and downs, because one of the things that is one of the early signs of insulin resistance is reactive hypoglycemia, meaning you get reactive low blood sugars. So you eat breakfast at 7 in the morning and that insulin is working to bring your blood sugar down, but then it is mistimed a little bit. So then it crashes your blood sugar, let's say at 11 a.m. And then you get jittery and shaky and hungry. And you might see that on your glucose monitor. That's a sign that maybe you have more insulin resistance than you think.
Interesting. Okay, so let's talk about this. Different ways, like you said, we can do a blood test to test insulin resistance, and you like that even better than that hemoglobin A1C number?
I do. It'll show abnormalities before your A1C goes up.
Okay, so if
Yeah.
somebody's sitting happily at like 5.6, 5.7 hemoglobin A1C, their insulin resistance number could still be saying, hey, look out.
Yeah. And actually anything above 5.1 is insulin resistance.
Okay.
So,
Okay.
yeah, every time you go up by 0.1%, you double your diabetes risk past 5.1.
Okay. And think about how many patients are never talked to about this, right? Like, I feel
Yeah.
like we get a number back. It says within normal limits, and we think we're good to go. And we're not
Yeah.
out to scare anybody today. I feel like I need to
No.
say that right now. Just knowledge is power. And once we
Yeah.
know, then we can start to investigate. I just got to
hmm
throw that out to the world. So, is it ever too late to be investigating? Because I think we could have pushed some panic buttons on that too for the person going, I am a total carbaholic. I never eat protein. Like, is it too late for me? What's your talk?
No, I mean, people asking me that about the hormone therapy, like when am I too old to like when should I stop my hormones, and stop them at your funeral? Like you're going to live every day of your life in your body. It's never too late to change. And I've had some awesome results in patients in their 70s and 80s where they think they're not going to change how they eat, and they do.
And they see results with it,
And they see
right?
results like I can actually lose weight now.
Yes. Oh, thank you for saying that.
Yeah.
I definitely think that I've got this population of 50s, 60s who have checked the box and said, well, I guess this is the new me and
hmm
my body will never drop. And which is one of the questions that I wanted to go into with you is just giving this we'll call it a case study. And I know that you have this woman walk through your doors all the time too. But the person who comes to you and says, one, I can't lose weight, or if I can, it's so hard and then it's so easy to gain. My anxiety has increased. My sleep has decreased. I'm not sleeping as well. And I'm honestly chalking this up to, I guess this is just my age and now how I have to get used to living life. I want you to walk us through your conversation, but also this step by step, like what are the next action steps for that person to take?
Yeah. So the number one thing they have to do is they have to start doing research on what their symptoms are and what treatments are out there for them. Most of my patients, I'm not the first person that they've talked to about those symptoms. It's very common in primary care. You see a patient with all those symptoms and you can offer them birth control or antidepressants, but you don't really have much else in your toolkit. So step one is to find somebody who can actually help you with different tools. A good place to start with that is to find a compounding pharmacy that is reputable and call them and say, hey, do you have any providers that you know of that I could see to help me get my life back on track and rebalance my hormones and get me feeling better? I used to think that if I could get someone to change their diet to the perfect extent and get their exercise dialed in, that I could fix them. But there's a wall that people will hit, even with exercise and diet. Not everybody hits it, but most people do. where hormones kind of, you have to fix the hormones too, or you won't get full disease control or full disease remission. So that's why I would recommend going that route, is going through a compounding pharmacy and then finding that provider and making sure that they're a good fit for you and getting that consult done and making sure that they do comprehensive blood tests. So the reason I'm emphasizing blood is because there are some hormone providers that use Dutch testing. Dutch testing is urine-based hormones, and they can also do saliva testing. Unfortunately, saliva or urine hormone levels don't correlate with blood. So you can have unreliable information that you're using to dose and adjust the dosing of hormones, and it can be dangerous.
Yes. So with that, just like for comfort, is there a baseline that like even if you didn't necessarily need that hormone, it still wouldn't be a negative thing to be getting it just to cover a baseline? Or how do you feel about that thinking?
You mean like using a urine or saliva level just to start?
Yeah, let's pretend that we don't trust the tests that are coming back. And you're still getting some recommendation, compounding bioidentical hormone of let's get you started on this. Can that trust level still be okay? Even, I don't know if like, because I
I
think
don't,
this is where people get so nervous. They're like, I don't know if I'm going to the right person, if I'm getting the right
right.
information.
Yeah,
Yeah.
they need training. That's one area that's easy to suss through. Are they using blood testing? Because blood testing is the gold standard. And when you stand in front of a medical board and you're defending your therapy, if you don't have blood tests, it won't stand up to the standard in the literature, which is serum testing for
Okay.
hormones.
Okay.
So
Thank you.
that's the first step. But honestly, if as long as you're on the right route of
Mhm.
administration of the hormone, then it really, your levels don't really matter as long as you're getting something. So you need to be on oral progesterone, not transdermal.
Okay.
So otherwise you're not going to protect your female organs from estrogen that you're on.
Oh, it goes deeper and deeper, doesn't it?
So then, yeah,
Okay.
then you go, you find a provider through a compounding pharmacy, and then you go to the consult and make sure you ask them first, do you do blood tests or do you do Dutch? And if they say blood, then give them a
Keep
shot. And
going. Okay.
yeah, this is just
Okay.
like my advice. Take it as you will, but that's what I would do if I was a patient looking for a provider.
Yes, no, that is absolutely why I'm asking. And here is something that played in for me after we had talked and I had done a whole menopause hormone series. I looked into an integrative center by my house just to investigate like what that process would look like. I should go through this first so my clients can jump on board. Well, the first 70-minute consult was going to be $560. And I have to say, it's a little hard to sign up if you don't have all the symptoms going with it. So, my
Oh.
question to you would be help nudge me in that direction. Like every woman of a certain age, we should all be committing to this cost, committing to this investigation to set ourselves up for success for later.
Yeah, if you dial in your metabolism and your hormones, you're practicing the highest level of preventative medicine you can. You're not waiting for, this is an analogy Dr. Rouzier uses for dementia. Don't wait for the house to burn down. Once the house is burned down, i.e., you've got severe brain damage, you're pretty much committed to that process because your house burnt down already. If you have a small kitchen fire, stop, put it out, remodel the kitchen, and then the rest of your house is already fine. And that's the approach, is like the younger you can get optimized and get on the right eating plan for your body and get on the right supplements, the better you will age. You'll age better, you'll keep more functional status, you'll keep more muscle, your mental health will be preserved. When I listen to some of the stories my older patients tell me of how their menopause went, I'm like, oh my gosh, I can understand how you had a really hard time. If
Yeah.
you can get on progesterone when you get the first few signs where you're having maybe a little bit of night sweats or insomnia or anxiety or irritability, you won't even know you went through menopause. I've had a few patients where they're like, maybe I'm in it now. I don't know. And we check labs, like, oh yeah, I guess you are. Here's some estrogen, rather than this like huge battle of sticking your head in the freezer and feeling out of control.
Yes. Oh my goodness, yes. So then the next question that comes with all of this. Now, you and I have talked, we've talked menopause, hormones, we've talked insulin resistance, and oh, thyroid was the other big
Mhm.
one. And there's also food sensitivities. Like there's a lot of moving components with this. And that was also with the integrative center that I was about to go into. Like, they're going to maybe investigate any of them when you think you're maybe going in just for this weight loss consult or menopause
Yeah.
consult. How do you walk somebody through this is how that should all flow so we don't feel like we're testing for something that we don't even
Yeah.
need at the moment? Because it is all money.
So all of my patients go through comprehensive blood panel. We have a really detailed history we go through of like history from when you were a baby all the way up to current age, family history, things like that. I don't require my patients to get other testing like genetic testing, food allergy testing, gut testing, unless it's indicated. So not all of my patients will go through that route because maybe they just have some mild perimenopause. They need a little bit of thyroid and progesterone and they're a happy camper. And we deprescribe a couple medicines that are maybe contributing to their insulin resistance, which is a whole other topic. We get them off those meds and they're happy and they're off to the races. Other people are highly medically complex. They have multiple comorbidities. They need other testing, but it's not a one size fits all. So most of my patients just need the blood panel.
Okay. That's good to know. And I love that word indicated, only if indicate. Like, if you're seeing something that is triggering you to go, we have to investigate this, or we're missing a big part of the picture.
Right.
And do you do
So
stool samples on patients often?
we do mostly for patients that are having significant GI illnesses that have already been worked up extensively. They've had scopes, they've had upper and lower scopes, I should say. They've already had the GI testing that clinics already offer, which is basically just looking for some bacterial pathogens. They've already had the parasite testing that's available at your local doctor's office, and they still don't have a reason for their issues.
Mhm.
And then we'll do comprehensive GI panels where they actually look at like what your counts are for your gut flora. What are you missing? Do you have any issues with secretory IgA, which is part of our first line of immune defense in our gut and is responsible for gut integrity? So it gives
Mhm.
us a lot of information and also helps me tailor what probiotic to get. Because if you take a probiotic without knowing that, then you can actually accentuate imbalances you have. So let's say you
Mhm.
have 8 good bacteria that are doing well, but you have 2 that are close to zero. If you take a probiotic that has all 10 of them, you're going to further support the 8 that are doing well. And those 2 that aren't doing well might not have enough food to grow. So you might accentuate the imbalances.
Yeah, interesting. So interesting. Okay. So if somebody comes in and they're like, I'm really coming in because I'm super annoyed I can't lose weight,
Mhm.
then they wouldn't necessarily get immediately put through gut issue
Right.
testing.
Yeah. Exactly. Yeah.
Yes. Okay.
So it would be more like, okay, we need to do all of your metabolic and hormone testing and then figure out if you have symptoms of other hormone problems and then
Mhm.
replace those. And then we put people on different diets depending on their goals.
Do you feel like they can get results without having to go on a per se diet? Like, yes, look at food, but can you have moderation with food changes when the other things are happening? And I do want to visit the medication topic with
Mhm.
you with insulin resistance. Like in my head, there's this equation of nutrition plus fitness plus whatever that is, like medication or hormone equals now we can finally see results where I've seen people who don't have that other third component really struggle with that uphill battle of like a pound here and there.
Right. A lack of control over your eating where you're just eating sugar all of the time and you're stopping at gas stations to buy candy bars and you're getting up in the middle of the night to eat ice cream. Those are actually symptoms of insulin resistance and hormone deficiencies. We shouldn't really be that dysregulated in our appetite. So a lot of patients will experience reduced cravings and improved appetite towards foods that are more nutritious. Like I actually felt like eating a steak. I didn't have to force myself to eat eggs in the morning.
Mm,
So there's a passive improvement in appetite and satiety with the hormone optimization.
yeah.
So some patients will lose weight without changing their diet at all. but they do actually change their diet unintentionally. It's just they're not trying to.
Best case scenario.
Right. But there
Yes.
are other people that have things that they're so insulin resistant, or they've been insulin resistant for so many years that unless they really shock their system and really change their diet, they're not going to lose much weight. They might lose slowly, like 5 pounds a year, but they're not going to make big changes.
Okay, so let's go this medication route. Let's talk there for a second. We promised insulin resistance talk, so this is a
Right.
piece of it.
There's a few big player meds that I look at on someone's list that can contribute to weight gain via increasing insulin resistance. And also part of the mechanism of the increased insulin resistance is blocking certain hormones. So one of the biggest drugs that people are on are cholesterol medications or statins. There's a study that was recently all over social media where they measured people on statins. They measured their metabolic markers. They measured their glucose, their fasting insulin, their GLP-1 levels in their gut. And GLP-1 is Ozempic, basically. And they found that statins reduced GLP-1 levels by 50%. So we know what GLP-1 does. It reduces appetite, improves insulin sensitivity, and it doubled their insulin levels and it raised their A1C.
Wow.
So if you're on a statin, you have more insulin resistance than if you're not. So how do we fix your lipid panel? Well, we can do diet and hormones. We can fix the lipid panel that way. But then the statin medications, a lot of people get put on it when they're already in early stages of insulin resistance because their lipid panel looks abnormal. And then that further accelerates their weight gain and then accelerates their time to being a diabetic. So they're diabetic faster and can cause secondary high blood pressure, which gives them another risk factor. So that's a big one that a lot of people are on as a preventative. Another big drug class that increases insulin resistance are antidepressants, SSRIs. So like Lexapro, Zoloft, because of the serotonin effect and also direct insulin resistance effects, they can put on weight due to the increased insulin resistance.
Mm.
And then both of those drugs also in men block testosterone by 50%.
Mm.
And
Wow.
testosterone in men and women actually helps you maintain your muscle mass and your body weight.
Wow, yeah, that's going to be mind-blowing for a lot of people that this preventative medicine or to keep what we think a balance of normal looks like is exacerbating our other symptoms to worse health down the road. Man, that's a hard
Yeah.
topic. I know. So I thought you were going to go more, and I'm so glad you went this direction. I was thinking more of the preventative, like let's talk GLP-1s and those because they're such a hot topic right now.
Yeah.
But this is more motivation when you're told you have high cholesterol, attack it with food and fitness way before you'd think meds, right?
Right.
And then do you have your patients do the ultrasound to see inside arteries? Because I think that's the next thing. It's like, where are we in the process? How much blockage do we have going on? Do you kind of nudge them, let's get an inside looks to put your mind at rest that we can just do food and fitness right now?
I will generally do that in patients that are higher risk. I use a coronary artery calcium score because that's what's readily available in my area. Where that you do a CT of the heart and you count up how much hard plaque you have in your coronary arteries, and you get a score from 0 up. The higher the score, the more plaque you have. And that score, you can repeat it in 3 to 5 years to see it going down on treatment.
Okay. Okay. So yeah, your eyeballs are on it. Yes. Which again is comforting if we can be told, hey, we're on this. You have time to work on food. Because I think individuals' panic buttons get pushed that I have high cholesterol, I'm gonna have a heart attack.
The other thing with statins too is if you tell somebody you have a problem with your cholesterol, here's a medicine, and that medicine is fixing the problem. That patient has this false sense of security that I'm on a cholesterol medicine. I don't have to worry about that. That's fixed. I don't have it anymore. Just like people in the emergency room, they think that they don't have high blood pressure because they're on a couple medicines for it and it's normal now. Well, you actually do have high blood pressure. We're treating it. So they take a very passive approach to their health. And I think that's damaging because you're putting the responsibility on this cholesterol medication instead of yourself.
Right. Yes, that's such a good point. Please walk us through back to that equation of if a patient needs a medicine for insulin resistance, where do you start?
Yeah. So the first thing we do is we look at how severe their insulin resistance is. So there's 15 or 20 things you can look at in your blood panel, and I can say, oh, you have 90% of the signs or 5% of the signs. And then we go through like how they're eating, how their sleeping schedule is, what their work is there stressors involved, like night shift workers, et cetera, have a harder time. And then generally we try to get them on a diet that promotes more whole foods, less processed food. And we try to reduce these like small frequent meals that are spiking blood sugars frequently,
Mhm.
and increase the foods that have more satiety, so like proteins and fats. That's a way to immediately help with the insulin resistance. And then medication wise, if they have thyroid symptoms, we will optimize their thyroid, which helps their metabolism improve. And one of the side effects of improved metabolism is weight loss. And then testosterone, if they have symptoms of low testosterone, we can optimize that as well, which will then improve mood, motivation, energy, sex drive. Once patients have been optimized on those specific two hormones before menopause, and once you're in menopause, you need estrogen too. If you're a female, we'll add progesterone. I usually make patients stay on hormones for a good 3 months before we explore adding any weight loss medications. And there's a couple different options. You can go with pills that will help suppress appetite, like phentermine. Phentermine is a very limited use drug because it only works for a few weeks, and it generally doesn't have long-term, like you regain it usually with phentermine. So unless your hormones are fixed, I don't use it really before then. And then there's things like growth hormone or growth hormone secretagogues, which make you produce growth hormone. The secretagogues like sermorelin can work for a couple months, but then your body stops responding to them. So you can't use them very long. And then growth hormones like $1,500 a month. So very few people can afford that.
Yeah.
And then you have all the sexy GLP-1 drugs like Ozempic and Mounjaro, which work very well. But if you put somebody on that right away without fixing their other hormone problems, you end up with a lot of muscle loss. And also people don't learn how to eat protein. And if you eat popcorn and chips when you're on semaglutide or Ozempic, your appetite's so low, you're going to feel full quickly. You're going to still lose weight, but you're going to become malnourished. You're not going to get the protein that your body needs and the nutrients. So I really try to get people on that first, and then we'll introduce other weight loss medications if they're not seeing anything change.
Okay. And metformin, what are your feelings on that?
So metformin in men blocks 50% of your testosterone.
Wow.
So I'm not that thrilled with that for men. And in women, I only use metformin really for PCOS patients to help reduce their miscarriage risk if they're trying to conceive.
Okay.
Most of the metformin, like long-term weight loss from metformin, maybe 5% of people will lose weight from it.
Mhm.
We thought it was going to be this miracle drug for weight loss, and I just don't see it in clinical practice being that helpful. And a lot of people have issues with tolerating it from the GI side effects. So, yeah.
Yeah. And going back to the GLP ones, the short-term thinking for you, like I know that that's not what the company is necessarily saying. They're feeling like long-term might need to
Mhm.
be on it, but can you see it as just a jump start to kick the weight loss into gear and the idea to come back off of it?
Yeah. And that's what most of my patients want. They don't really want to be on that forever,
Right.
but it is helpful. Like if you are 500 pounds or 600 pounds, a lot of weight to lose. And if you have
Mhm.
something that's helping in the background improve insulin sensitivity, reduce the gastric emptying speed so you feel fuller, it
Mhm.
also centrally disrupts opiate pathways so that you get less reward from food. And also, I will use it off label too to help people with addiction to like alcohol and other things because it helps reduce those cravings.
Yeah. Yes. And I think this is like anything. We just need to go in smart, right? That we need to understand all of it. And then it's never the end all be all fix. It's
Mhm.
just a tool.
Yeah.
And you have your tools in line as far as like what you start with before you'd ever even get to some of the meds. So thank you. That was such a beautiful walkthrough of you would address that helps me. Thyroid is one of your first things you address and
Hmm.
insulin resistance before you go hormones even is what it sounds
Yeah.
like, right? Yeah.
Well, the thyroid is a hormone. So then we kind of, we address that imbalance. And I would say one out of 4 or 5 of my patients will end up on a weight loss medication.
Mhm.
So it's
Interesting.
not everybody, whereas there are some people that approach it with everybody gets Ozempic, but there's downsides to just using it by itself.
Right. Right. Okay, what have we not talked about within this that we're missing with any form of insulin resistance or any tips or tricks you have?
Well, I think that the main thing is to be aware of what normal range really means. And if you're in normal range, but you're not in optimal
Yeah,
range,
yeah,
you could be sick and you might not know it. And so
right.
just to pay attention like that, there's more to it than just looking at whether you're in the normal range or not and where those normal ranges come from. Often it's old people or sick people or old sick people. So you have to go to somebody that knows how to interpret the labs to the point where this is a healthy level, not just this is what is in normal range. And that will set you ahead of other people that are just relying on, well, I'm still in normal range, so I'm good.
Hmm. I know. I feel like I have those conversations all the time with my clients because even something simple like B12 or vitamin D, when you're sitting low, it's not optimal, right? So
Right.
it's
Hmm.
too easy for us to get that phone call from the doctor. You're good. Check, and you're like, wait,
But
let's
it's
talk about
funny
this.
you mentioned vitamin D. Actually, low vitamin D is another sign of insulin resistance because vitamin D is involved in insulin secretion and insulin regulation. So when you have insulin resistance, you have a much higher requirement for vitamin D.
Hmm. All right. That's good to know. I think
Yeah.
when I used to be in the office and in the hospital situation, everyone's vitamin D. I mean, I say everyone. I'm going to say 95% of individuals' vitamin D levels came back low to quite low,
Hmm.
that, but I think we're getting better about testing those. I know we're not great about getting the hemoglobin A1C, and I definitely know we're not good about getting the insulin resistance test. Like, you'd really have to ask for that from your physician. Do you
Yeah.
find that?
Hmm.
Yeah,
Yeah. And they can be denied by insurance and can be quite expensive, which is why we do cash labs because even if they denied a vitamin D level, it could be a couple $100 just for that vitamin D level if it's not covered.
right. Yeah.
Hmm.
And then same thing with, yeah, okay. Thank you. That is so helpful. I would really like you to shout out the next steps of if a listener would like to work with you. My mom and I were both like, do we take a road trip after we talked to you the first time? Because there is this virtual option,
Right.
but sometimes you have to go see you once in person. So walk us through that process one more time.
Yeah. So the easiest way is to go on our website and email our clinic directors, basically where those emails go, and then he arranges getting you scheduled with for a consultation. The consultation fee that we charge is $300, and that covers the initial consult and then also the visit that we meet again to review results for. People that live outside of North Dakota will usually go through a lab core to get their blood drawn. Or if you live locally, we do it in our office and we mail those samples to Florida where we have a cash pay lab that processes them for us. And then once we meet to discuss the results, you decide whether you want to go into treatment or not. And at that point, whether the consult was with me or one of my other providers, you would get scheduled for your first follow up and kind of enrolled and consented for the hormones and the treatment.
Okay. Okay. So it is step by step. And if somebody just wanted to dip their toe in the water, that first
Mhm.
initial consult is the jump off point.
Yeah,
Okay. Thank you.
no
What
problem.
else? What else do you have coming up exciting? Anything you want to shout out to the world?
We have our open house in Fargo coming up next week. So we'll be having everyone come through and see our new space. Pretty excited about that. And then I'm excited. I'll be speaking at WorldLink's conference again in the fall. A couple different topics to be determined, but I'm looking forward to that again.
Does that get recorded? Is that something that we can get our hands on, or do we have to be at the conference?
You have to be at the conference or you have to be a virtual attendee. Like you can actually attend remotely and just watch it
Yes.
remotely. But yeah, it's in September in Texas, but there's a lot of virtual attendees as well.
Okay, that's good to know too. I've had some physician friends, again, like we kind of talk about all this as we go and just wanting connections as well to what
Mhm.
you've experienced, possibly to you, all of that.
Mhm.
So that's good to know. That would be a good starting point. Okay.
Yeah.
So I will put links in the show notes for anything that Dr. Levitt and I talked about today, including that blood glucose monitor. I'm going to grab that from you. And I like for you to send out our listeners with one last, if you heard nothing else today, what do you hope and pray they heard out of you?
Don't be afraid to look under rocks and dig to find out if there's anything lurking in your physiology that you're going to get sick from later. Think more in the future than your body wants to think of now, and find somebody that's going to do a deep dive.
That's so good. Thank you. You're wonderful.
Thank you so much.